So Brandon's question is, do we ever use prophylactic antiemetics if we're putting someone on NIV?
You asked if there's, basically to summarize what I'm getting is, if you think something you're going to do to the patient is going to make them vomit, does it make sense to pre-treat them with Zofran or something else? Does that summarize well?
Yeah, so there's any evidence behind it? Like, if there, are you aware of?
Has anybody done a randomized controlled trial for prophylactic Zofran?
Sadly, not to my knowledge at all.
Okay.
If you've got someone on NIV that you're really worried about puking, you should question your motivations with NIV, because if that's really a major concern, then they're probably not a great candidate. So a pancreatitis patient that's vomiting repeatedly and then gets hypoxic, that's a disaster waiting to happen. If you've got that normal, like, oh, I'm looking great, and you're just saying like, oh, you look great, I'm just trying to decrease Mrs. Magruder's chances of puking when I'm putting her on NIV, that's a different question.
And I mean, let's be honest, if Dan hasn't read about it, I probably haven't read about it. But I tend to use the common sense test of medicine. So yeah, if somebody's in a lot of pain and I'm going to give them a whole bunch of narcs and they're naive to it, it makes a lot of sense. If I'm worried what I'm going to do is going to make them throw up, I will pre-treat with Zofran. It's almost entirely benign. The only time I would not do that would be if they have a really long QTC, like over 490, 500, would be the only reason I wouldn't.
So as far as NIV particularly, I never pre-treat, because honestly, if it crossed my mind to pre-treat them, then they're probably not a candidate for NIV. And there's not great performance of these medications. It's kind of heartbreaking that we don't have better antiemetics. But recent papers have questioned whether Ondansetron, or Zofran, as my colleague who clearly sold out calls it. He's getting money from Big Z, I'm sure. But if you're using those medications, they maybe mildly decrease the number of episodes of emesis, but they're not magical. A big part of it is probably placebo, unfortunately. And considering how much it's terrible to feel like you're puking over and over again, these are not robust medications for that.
If you give somebody on NIV phenergan or promethazine or ondansetron or whatever you want to call it, and you send them up to the unit, they're going to get tubed. I mean, period. I had a big discussion with our critical care fellows, and I actually saved one guy from getting intubated because they gave him promethazine down in the ED because he said he felt nauseous, and that automatically was going to buy him an intubation when he was sitting there talking to me off NIV, perfectly normal, denying that he was nauseous, and he was coughing up frothy sputum from his bad pulmonary edema.
So it begs the question, should we send anybody to the ICU on NIV?
I think it's fine, actually. I think NIV is a life-saving measure that a lot of people get tubed that don't need it. You just have to make sure that you've got an end goal. Like if your thought is that they're going to be on NIV and they're going to stay on NIV for the next 4 days in the MICU, that's unrealistic. That just is not happening with hardly any of our patients. Those guys eventually get tubed. And there's some data that people that fail NIV and then have to get emergently tubed, like a crash tube, do poorly compared to people that are like, look, NIV is not working that great, let's just tube this guy. Those folks do a little bit better. So if they're not getting better with NIV, I'm not saying that people never get better like hour 7 of NIV, but most people that are going to get better from NIV aren't going to take forever and a day to get there. They're going to have some clinical improvement through a reasonable ER stay or a short MICU stay before they declare themselves.
And I agree. It's just when they're running serial ABGs and their hypercarbia is improving on the NIV to an acceptable level, I think that you should be able to keep them on NIV.
Agreed.
Instead of having them eat a tube for no good reason, just protection of their airway overnight.
100% agree. Like if they're flying, and let them get better, not because of our care, but despite our care. But to be honest, this is a related topic of, does these antiemetics improve the feelings of nausea? Which I'm sure you've had lots and lots of nurses come up and say, hey, bed 11, he hasn't thrown up yet, but he feels nauseous. Can we get some orders for some meds? Fortunately, there's really not great data that these medicines actually improve the sensation of nausea. They may decrease how often you puke, but the feeling of nausea is not something that medications generally do a great job of. As a practical point, one of my favorite orders was in residency was 1 milligram of Dilaudid PRN pain, Q30 minutes, dose limit of 3, along with Ondansetron 4 milligrams, PRN nausea times 1. because you're going to get asked that a lot, and it's up to you as a clinician whether, like, is there enough harm from this? As Jed pointed out, it's a fairly benign medication. These folks that are getting lots of IV medicines generally are soaking up a lot of resources anyway. Is it a terrible thing if they get a little bit of Zofran? It's not, in my opinion. But you have to know in your heart that this is not a super evidence-based thing, that there's not great data that shows that it works. And you need to make sure that you have a conversation with patients, especially being discharged with gastroenteritis, that yes, you're having diarrhea and that's going to continue for a little while and you're puking a lot. And we've got these medicines that may slightly decrease how much you puke, but you're going to continue to puke for the next couple of days. This is not a perfect drug. I think that's where Jim Wild points out some great points of you're medicalizing it a little bit, that puking is unfortunately part of life, and these meds aren't great at it.